Hello, this is Jody, and this presentation will cover coronary artery disease. Please use your textbook as a resource for this topic. The exemplar is found under the concept of perfusion. Here are your student learning outcomes. Please review these, use these as you are studying the material. I know that they're broad, but at least if you use them, you should know what you're focusing on when you're studying. So just an overview, look at the image of the heart, notice the arteries that are feeding the heart muscle. The heart muscle, which is the myocardium, receives blood, which contains oxygen and electrolytes and nutrients, which support heart muscle contraction. That heart muscle contraction is what pushes the blood out to the rest of the body. So if blood flow to the heart muscle itself is impaired, the heart muscle may not perform as it should. So we will discuss three things that can happen when blood flow to the heart muscle is impaired. Angina, which is chest pain that is caused by reduced blood flow to the heart muscle. In other words, the term angina, when talking about chest pain, is specific to reduction in blood flow to the heart. If someone has chest pain related to coughing or an injury, this would not be called angina. It would be chest pain secondary to trauma or something like that. So acute coronary syndrome is a sudden reduction of blood flow to the heart muscle, and acute myocardial infarction may be preceded by acute coronary syndrome, but a myocardial infarction is prolonged ischemia, which is that lack of blood flow and oxygen to the tissue that will result in irreversible damage to the tissue, which is the heart muscle. So that can be caused by complete blockage to the area of the heart muscle. So it's important to teach health promotion strategies. We want to prevent atherosclerosis, which is the buildup of plaque in the arteries. So cholesterol management is very important, whether it's achieved through diet and exercise or a combination of diet, exercise, and medication. The first sign of coronary artery disease is generally a myocardial infarction or heart attack. So teaching clients at risk for CAD is beneficial. So think about that. I mean, you're not going to have patients that come to a cardiac unit, because we think they're going to have a heart attack, right? So most of the patients that I've taken care of that end up having a heart attack in the hospital are on a med-surg unit, or they're, about to go to the OR or something like that. So that CAD is that first sign that they have coronary artery disease. So once we know that they are having a heart attack, then they go to the coronary or the heart unit, and we'll take care of them there. So I want you to watch this animation. This animation is really great because it demonstrates how the plaque buildup, that atherosclerosis can block blood flow. If it happens over a long period of time, collateral circulation can develop. See that just came about there, which are minor vessels that become active and reroute the blood around the blockage. However, this will not occur if a blockage forms suddenly. So this is important to note. So if you have somebody who throws a clot from somewhere else in their body, they did not have this buildup over time where their body activated this collateral circulation. It was an acute, unexpected blockage that occurred, then they're not going to have that collateral circulation. So think of what could block blood flow. Envision traffic flow in busy cities. I don't know if any of you guys have been to New York, but I used to live there and it was crazy. When things are good, the traffic flows smoothly, but if there is an accident or a parade or construction, traffic slows down significantly, and it is going to take longer for the cars to get to their destination. So now think of blood traveling in the body. Blood vessels need to flow, or blood needs to flow smoothly so that it can provide oxygen and electrolytes and fluids to the organs and tissues. Okay, if something like a partial occlusion, if something like a partial occlusion or a drop in blood pressure from an uncontrolled bleed or shock, a spasm of a vessel happens, it's going to take significantly longer for the blood to get to its destination. That delay in blood flow to the heart causes symptoms, and the most common symptom is angina, which is that chest pain from decreased blood flow to the heart muscle. There are three types of angina that we'll talk about. Stable angina, which is predictable. So basically when I say stable angina is predictable, is somebody has probably some occlusions that they're managing conservatively. So a patient may be on medications, maybe they're not a surgical candidate, and that they know that if they get up and they get their heart rate up too much, or say they can get up and they can function in their house, but if they walk down their long driveway to their mailbox, they know that they're going to have chest pain. So it's predictable. We can predict when that chest pain is going to happen, so we can start developing a plan to prevent that chest pain. Transmetal angina is unpredictable, and it often happens at night. And then unstable angina increases in frequency, and this is an increased risk for MI. So these are these patients that come in and they're like, yeah, I've had some chest pain here or there. You know, I noticed it when I was out walking the other night, and then I had some this day, and I've really never had it before. And, you know, now it's starting to come with increasing frequency. Well, this patient's now at risk for having an MI. We need to do something like an angiogram to look at the vessels to see, is there a blockage that can be treated? Maybe start the patient on some medications, stuff like that. So acute coronary syndrome occurs when there is a sudden decrease in perfusion to the heart muscle. Okay, this is different than a heart attack, and I know that many students get confused with this. But if you review the graphic on the slide, okay, we will take it as far as the cardiac markers. The most common cardiac marker used to help diagnose an MI is a troponin. So, for example, you're caring for a 62-year-old client who's on a med-surg unit who has developed GI bleed. The client's blood pressure has quickly dropped to 78/52, and the client is complaining of chest pain and dyspnea. You send stat blood work, which includes a troponin, and you start the client on a fluid bolus and obtain an EKG, which shows just sinus tachycardia. The blood work comes back, and the troponin is negative, and based on the hemoglobin and hematocrit results, the client receives 2 units of blood stat. So between the fluid bolus and the blood, the client's chest discomfort and dyspnea resolve. Their troponin remains normal. So this patient experienced angina. So it was chest pain caused by decreased blood flow to the heart muscle. But this would be considered acute coronary syndrome because it occurred suddenly and it resolved once the underlying problem, which was the blood loss, was treated. Okay, so the underlying cause was not an occlusion of a coronary artery, which would lead to a heart attack. So while acute coronary syndrome can be a result of somebody who maybe just had an MI that caused an acute reduction of blood flow to the heart and reduced that coronary cardiac output. It's different because acute coronary syndrome, it can develop from things like hypovolemic shock. Okay, so that's the difference. I don't want you guys to stress over this. This isn't anything major. It's just so you understand that you can have a patient diagnosed with acute coronary syndrome, but they didn't have a heart attack. They had reduced blood flow to the heart that was a result of overall blood loss. And once that blood loss was treated, the symptoms resolved and the heart muscle itself went back to normal. Okay, so I hope that makes it a little clearer. I know students get really frustrated, but it's not like you would get an exam question that asks, like, is this acute coronary syndrome or is this a heart attack? It's just so that you understand it, okay? So an MI, or a myocardial infarction, is a complete blockage that will result in tissue death. So the area and amount of area of the myocardium that is impacted will determine the client's output and plan for management. So you can have patients who have an MI. So if you look at the coronary arteries right here and you see where they're feeding this heart muscle. So if this patient had a huge occlusion right here, right before this branches down into both of these areas, they're not going to have a great outcome because they're going to have tissue death all the way down in here, okay, because it can't perfuse down in there. Whereas, let's say you had an MI way down here and this occluded, and then your tissue death was maybe right here, it's probably not going to really impact cardiac output that much because you really don't have a lot of tissue death over here. if you think about the left ventricle is what's pumping, is your main pumper to the body. So if you have an MI way up here, if you have an occlusion way up here and blood flow can't get down to any of these areas down here, you're not going to have a good outcome. So we have to talk about normal sinus rhythm before you can move into the abnormalities. So for 212, you will need to know what normal sinus rhythm is. You'll need to be able to recognize ST elevations, which are indicative of an ST elevated MI, myocardial infarction. So the patient is actively having a heart attack right now. And then atrial fibrillation. So those are really the three rhythms I want you to recognize for 212. In 222, you're going to go into more lethal dysrhythmias. But for 212, I want you to know what normal sinus rhythm is, what normal sinus looks like, what atrial fibrillation is, and then what ST elevations look like. Okay, so when we talk about normal sinus rhythm, you have the P wave, which is right here. So if you see it down in this strip right here, that represents atrial depolarization. So this is your top of the heart, your atria is contracting, okay? The QRS complex represents ventricular contraction. So this is your QRS here, right down here. So it follows the P wave. And so you should always have a P followed by a QRS followed by a T. So your P is your atrial contraction. Your QRS is your ventricular contraction. Okay. And then the T wave, which is this wave that comes after, this represents repolarization. So basically the heart is charging back up to do it again, to go through and have your atria contract and your ventricle contract, okay? If it's between a heart rate of 60 and 100, it's normal, okay? That's a normal heart rate, so that's considered a normal sinus rhythm. Okay, it's important to note that heart rate, because if you had a rhythm that looked like this, but their heart rate was 50, 52, then it would be considered sinus bradycardia because it's under 60. If it still looks like this, but it's beating over 100, it would be sinus tachycardia. Okay, we'll talk about rhythms you need to be able to identify, again, which are normal sinus rhythm, atrial fibrillation, and those ST elevations, okay? If a client is presenting with symptoms of an MI, so symptoms of an MI can vary. So for most patients, we would say, they're having chest pain, their pain is radiating down their left arm. Some patients will say it feels like it's somebody sitting on my chest, or I'm sure you guys have heard that elephant on my chest, like something very heavy sitting on my chest, hard to breathe. But then there are some patients, like diabetics, that may not feel much of anything at all, so they might have a silent MI. And then there are women who may have more vague symptoms like back pain or jaw pain. So it's not always, it's important to look at rhythms. It's important to look at a patient, listen to a patient. Are they telling me they're having symptoms that could be related to an MI? So if you have a patient presenting with symptoms of an MI, and they rule in with positive cardiac markers. So again, they may draw off their troponins to see, do they have cardiac damage? But what we want to look at is their EKG. So do they have ST elevations? So you can have a patient that has something that looks pretty normal on their EKG and they have positive troponins. So they would consider that a non-ST elevated MI, okay? If they're having an ST elevated MI, it means they are currently infarcting. This is an emergency. Part of the tissue is not getting the oxygen that it needs. And if we do something now to reperfuse that area, we can prevent some damage from happening. So we'll talk a little bit when we get into stroke too, that there's a time window to treatment. If somebody is having blockage of blood flow to their brain, same way if they're having blockage of blood flow to their heart, if it's, if we know that we're in a certain window of time that we can do something, we can prevent permanent damage. Okay, so if somebody comes in having an ST elevated MI versus a non-ST elevated MI, then we want that patient to go to the cath lab. Okay, or like if we're in an outlying hospital where maybe they don't have a cath lab, they may give TPA, which is something we'll talk more about when we talk about stroke. That's that clot busting medication. The reason we want to give it, the reason we want to get them to a cath lab if we can. So generally what will happen is if somebody, let's say around Buffalo or Rochester, has symptoms of a heart attack, paramedics come, they do the EKG, they look, they see the patient's having ST elevated MI, they are going to get them to a hospital that has a cath lab. They are going to alert that hospital that they're bringing the patient in, and then they can activate that MI team to get that patient to the cath lab so that they can get in and they can hopefully, do ballooning and a stent to get blood flow to the area that is not getting the oxygen that it needs. So, all right, so let's see here. If you look at this over here, we have an ST elevated MI. So what is happening is if you look at the rhythm itself, you have a little P wave here, that's the atrial contraction. Then you have the QR, but look at the S. The S does not come all the way back down here. So that S should be coming all the way back down here, right where this line is, where everything starts, where the P is, and it doesn't. It feeds right into the T wave. Okay, so this is an ST elevation. Now, when you guys start talking about kidney disease, you're going to talk about elevated T waves. That's different. Okay, that's generally indicative of like a high potassium level, and you'll talk about that more when you get into kidney later in the semester. What you need to know for ST elevations is that this is indicative that the patient is having a myocardial infarction and we need to do something ASAP so that we can reperfuse this area and prevent permanent damage. So again, if you see the P wave and then you have the QR and the S does not come all the way down, it feeds right into that T wave. So if we go back and look at normal sinus rhythm, you see how the QRS comes all the way down and it matches the Q wave. So the S should come all the way down to the same level that Q is on. But in the ST elevations, that QR S wave does not come all the way back down to where that Q starts. Okay, it feeds into that T wave. So that's an ST elevation. Non-ST elevation is just, if you look back over here, so this is this is normal. So if we look at normal EKG, so we have the P, the Q, they have this ST not coming all the way down to the level of the Q, but it really should almost come down to the same level. And then you have that T wave. Here's the ST elevation. That S wave or that S does not come all the way down here. It feeds into the T. And non-ST, you do not have to know this, that it'll give you a little bit of a depression here. This is just when, cardiologists can take a look at it and say it's a non-ST elevated MI. They did have an infarct. There is a change after the heart attack in their rhythm. You guys don't really have to note that. You just have to know that this isn't an emergency. This means they've infarcted, there's damage to the heart, their troponins will be positive, but there's nothing we can do for them right now that's going to prevent any permanent damage, okay? And then sometimes with a non-ST elevation too, you'll get these T wave inversions. So there is abnormalities that can happen in the EKG, but this is not something that they would recognize and say, okay, we have to get them right to the cath lab. Sometimes what will happen is if they come in with a non-ST elevated MI, so they've had chest pain maybe all day, they come into the hospital, they do the EKG, they see some changes, they do the troponin's positive. What they might do is send them to the cath lab the next day, because they might say, yeah, they had an infarct, but maybe there is some risk for there definitely is risk for coronary artery disease there because they've had an infarction, but maybe there's something that we can do to prevent another one from happening. So they might still go to the cath lab, but it's not emergent. So ST elevation, they emergently need to get to the cath lab to see if we can reperfuse. So what I was saying about the TPA is if you had somebody who was really living, in an area very remote and they were very far away from, any cath lab, what they could give them is TPA in the hospital, which we'll talk more about when we talk about stroke. It is a clot busting agent. What they do is if they get them to the cath lab, they can actually deliver some of that TPA directly to the clot. Okay, so they can give some of that TPA in the cath lab if they need to. So we generally do not give them TPA and then send them to the cath lab because they would really be at high risk for bleeding when they put in that catheter. So if they do give the TPA, they would give it very locally to the clot during the angiogram, that cath procedure in and of itself. So it's very important to talk about modifiable or manageable risk factors. So smoking is going to be a big one for a lot of things that we talk about. So smoking cessation is something you want to teach your patients. Even if you have patients that say, I'm not going to stop smoking, I usually just try to go about the route of, okay, let's talk about this. You're really high at risk. Would you think about reducing at this point and then maybe quitting later? What are your goals in life? Do you, a lot of, like I had a patient once who really wanted to see his daughter get married, and she was getting married like a year from the time that he came into the hospital. So we sat and talked about it. Okay, that's a great goal. Let's talk about ways to get you there. And smoking cessation is going to be a huge thing that you can do for yourself to improve your health and help make sure that you can be there to walk your daughter down the aisle. So, smoking cessation is something it's important to teach and talk about with your patients, even if they tend to be a little resistive at first. Hypertension, do they have hypertension? Is this newly diagnosed? Are we putting them on medications? Are they already on medications? Are they taking their medications the way they should be? Obesity, so getting their BMI down, teaching a healthy diet, exercise, hyperlipidemia. So if their cholesterol is high, do we need to modify their diet? Can we possibly think about medications for this patient? If they're diabetic, are they managing their diabetes? Are they checking their sugars? Are they taking their meds as prescribed? Kidney disease, has that been diagnosed? Has it been treated? Sedentary lifestyle. Okay, nobody should be sedentary. Okay, we want patients to be active, even if they have heart disease. We really want them to be as active as they can be. So even when I talk to you about, stable angina, so you might have a patient who knows that they're going to have chest pain when they walk all the way down to their mailbox. Well, we want to do some education about what can you do within your limits. What can you do? Because being active is important. It is a preventative. Exercise and diet are huge, so what can you do within your limits? And I had a patient who let me tell you, her ejection fraction was all of, I think, 15%. She had a biventricular pacer, which we'll talk about more when we talk about heart failure, and defibrillator. She had multiple surgeries, but she still had this goal of being active and as healthy as she could be. So she would get on her treadmill for 8 minutes a day. That was what she could do, was 8 minutes on her treadmill. But she did it every day. Okay, so she worked within her limits. She was still active, even though she had this very severe heart disease. So it would be a very rare circumstance that we would ever tell somebody we would want them to be sedentary and laying around and not doing anything. Okay, because really, what quality of life is that? Right? Stress, reducing stress. So stress reducing strategies, teaching those, a diet that's high in fat and diet high in fat, cholesterol, and low in fiber. That is a risk factor. So if you look at patients who are out eating a lot of fast food, a lot of processed food, that is a risk factor. So we want to change that. We want to teach them heart healthy diet, which is low in fat, low in cholesterol, and high in fiber. So that would be lots of fruits and vegetables, lean meats, healthy fats. And then women, so menopause increases a risk, and so do oral contraceptives. And so that's something important to know. If you have a young patient, and I've had patients in their 20s and 30s and 40s come in with heart attacks and stroke, who, if you were to look at them, you would say, they don't look like somebody who would have a heart attack or stroke. But then you find out that they smoke, their diet's not great, and on top of it, they're taking oral contraceptives, which increase their risk. So you always want to look at the patient holistically. What are their risk factors? So non-modifiable, obviously we can't do anything about a person's age or gender or race, ethnicity, or family history. So that's why it's important to recognize that you might have a patient. So, you have, a 60-year-old Alaskan Native patient who has a family history of heart disease, you know that they're going to be at high risk. So you really want to pay close attention to the modifiable risk factors to help reduce their risk. Metabolic syndrome. This is something you guys probably have talked about, maybe when you talked about diabetes, but there's a group of risk factors that a person has that increases their risk for coronary artery disease. That group of risk factors is a large waistline. So I don't know if they still call it this. They used to, term it beer belly. And that's basically somebody who eats a lot of carbs and they tend to gain all of their weight in that belly area. Okay, so that combined with a high triglyceride level, low HDL levels in their cholesterol. So remember, HDLs we generally want to be higher, and LDLs we want to be lower. So somebody who has a low HDL level, and then somebody with hypertension and an elevated fasting BG of 100 or greater. So when you combine all of these things that a patient has, they have a very high risk for coronary artery disease. Also increases the risk for stroke and diabetes. So these were the SLOs that were addressed in this part 1 presentation. So we talked about atherosclerosis, which is plaque buildup in the vessels, which decreases coronary artery perfusion and can reduce blood flow and lead to total occlusion, which could lead to then tissue death, right? Angina, which is chest pain caused by myocardial ischemia, which reduces the blood flow to the heart muscle, can occur when there is a partial occlusion. So that's pathophysiology, right? And then we talked about acute coronary syndrome. So it could be something like a blood loss from GI bleed that reduces the blood flow to the heart muscle itself, plus increases the demand that the heart has to do, right? The heart has to try and pump to the rest of the body and get oxygen to the rest of the body because there's that reduction of blood flow throughout the body. So that can result in acute coronary syndrome. Okay, if they have total occlusion, it can lead to heart attack and permanent damage. You should understand the risk factors and teaching you would do for a client based on their individual risk factors. So, we're 4th semester now. So if you get questions on there like, you have a patient, this is what the patient looks like. I actually have a question, I think, on the next slide, so we can kind of talk through that. But we'll talk about it in the next slide. And then we talked briefly about the primary symptom of coronary artery disease, which is chest pain, okay? And pain falls under the concept of comfort. So we talked about kind of the relationship of perfusion to previously learned concepts. So think about that pain, comfort, basically you can get, we'll talk, when we talk more in class, we'll talk about the concept of infection and how that relates to clients who have coronary artery disease and they're going for a procedure like an angiogram or a coronary artery bypass graft. So here is a little case, like just a snippet of a case study. So the nurse is caring for a 36-year-old client on a med-surg unit. The client was admitted for repair of an ankle fracture. The client developed chest pain and their EKG showed the rhythm below. So if you look at the rhythm below, you say they have the P, the QR, and the S doesn't all come all the way down here. It feeds into the T. So that's the ST elevations. So what does the EKG show? What risk factors based on the client's chart should the nurse address prior to the client's discharge from the hospital? So now, if there were a question here to say patient has, like I said, 36 is fairly young, but 36 in chest pain, you do the EKG, you see this patient, priority is getting them to the cath lab. Okay, so they have the P, the QRS, we see the ST elevations here. We know that they are actively infarcting. This needs to be addressed right away. This is a medical emergency because if we get them to the cath lab and we treat this, we can prevent permanent damage. So in knowing the patient smokes a pack of cigarettes daily, their BMI is 24, their total cholesterol is 176, The client reports that she works in an office at a desk 5 days a week, and she spends most of her time at home watching TV. So this is sedentary lifestyle. Her blood pressure is high, and the only medication she takes regularly is an oral contraceptive. So we know that oral contraceptives, especially when combined with cigarettes, is going to increase her risk. So what would want to be addressed prior to discharge? So you would want to teach her smoking cessation techniques. So it might be, support groups, or you can give her, talk to her about medications that can help her quit, give her information on all sorts of smoking cessation programs. But this needs to be addressed. Okay. Total cholesterol looks okay. So diet probably isn't much of an issue because her BMI and her cholesterol are okay. Sedentary lifestyle. So we would want to talk about exercising. So the American Heart Association recommends for most people 30 minutes a day, 5 to 6 days a week. So we would want to talk about exercising and working that exercising into her regular routine. Now, her blood pressure, could be high because she's experiencing something over here that's causing pain, and that could be, but also we want to keep an eye on this. Does she have high blood pressure at baseline? Is this something addressed? She doesn't take any medications for it now. Does she need something for this blood pressure? So that's really thinking over a patient and individualizing your care plan and figuring out what for this patient do I need to teach? What risk factors does this individual have? So what would I put in my care plan to address that specific problem? And what I was going to say in the previous slide is when you get questions on exams, so say you have a patient, that has a risk for infection. So they've gone, to surgery, they have open wounds, open incisions, or not, maybe they're not even open, but they have incisions. So we have cut into their skin that puts them at higher risk for infection. So the answer would not be teach infection prevention. Okay. It would be what you are going to do for that patient to prevent infection. It would be, having the patient wash the incision with antibacterial soap or cleanse it or change it per whatever the orders are. So it's going to be doing something. And I say that it's the same thing as, teaching fall precautions is not going to be an answer in fourth semester. It's going to be the things that you teach a patient that are included in fall prevention. Teaching the client to put non-skid socks on, putting their call bell within reach, removing clutter from the floor. So you want to get very specific into what your interventions are going to be for a client based on what you would be teaching that patient. I hope that makes sense, but if not, certainly ask me in class. So that is it for part 1. I will put a part 2 video because I know that that's, it's a lot for, you guys to view. And this is stuck for some reason. It is not letting me go forward. There we go. So I will put a part 2 out. You guys can watch that. You should watch part 1 and part 2 prior to coming to class. All right, thanks.